All right, good morning, everyone. Welcome. We are on day 5 of Connecticut Coalition to End Homelessness, Housing Equals Justice, our 18th annual Training Institute and Conference. Sorry about that. We have some technical difficulties, but this is the session on COVID-19 guidance. This is a session where we will be have a chance to have a Q&A session with our federal and our state partners regarding how we can continue to adapt to the evolving nature of the COVID-19 pandemic with respect to homeless services. And again, I think it will be a really rich discussion, so really thank you all for joining. Next slide, please. As you all know, this conference is our 18th annual annual Training Institute and Conference. This year's theme is Housing Equals Justice, really highlighting homelessness as an issue of economic justice, racial justice, and also criminal justice. As we've been discussing throughout the week, with the backdrop of COVID-19, it's also an issue of health equity and justice as well. We've had many rich conversations today. Today will be a very, I think, practical Q&A session, or really talking about how do we adapt homeless services in the face of COVID. Next slide. Please help us tell the world that housing equals justice. Use social media, Facebook, Twitter, and Instagram. Those are our handles, and you can also use various hashtags, ATI 2020, hashtag housing equals justice, hashtag end homelessness. And really share what you're hearing and learning from this session with the world. And we also hope you'll visit our Housing Equals Justice store. This will be the store where you can purchase a number of items, including t-shirts, mugs, as well as face masks. We also have hoodies and other items, so please do visit that. You can go to our ATI webpage and click store, and that'll take you to our bonfire store. Great, and I then want to also just thank the sponsors for our entire event, Bank of America and Zillow as our presenting sponsors. We also have a number of workshop sponsors that have made this possible, and also made it possible for us to offer this week-long virtual conference as a event that's free of charge and open to the public. In particular, I want to thank the Connecticut Public Health Association. Roberta Friedman is here, who has made this particular workshop possible. So Roberta, please I'd love to have you say something.
Great, thank you, Richard. We are very pleased to be a sponsor of the workshop today. And just to tell you very briefly about the Connecticut Public Health Association, we are the state affiliate of the American Public Health Association, and I'm the chair of the advocacy committee for CPHA, and we do advocacy for better public health policies. We offer educational opportunities for our members, and we do mentoring for public health students in Connecticut. So we hope you will join us, and thank you again for allowing us to sponsor you.
Great, thank you so much, Roberta. Great, so we have really fabulous panel for here today, who can really hopefully answer as many questions as possible regarding how to continue to adapt homeless services in the face of COVID. Oh, if we go back slide, okay. We have, I'll just go in the order that's presented here, Steve DiLella, who's the director of the Individual and Family Support Unit at the Connecticut Department of Housing, probably no stranger to any of you in the audience. Joining Steve from Department of Housing is Leigh Shields-Church and Zichichi, both of whom are Coordinated Access Network Managers for the Department of Housing, and who you probably interact with on a regular basis. We also have Dr. Lynn Sosa, who's the Deputy State Epidemiologist for the Connecticut Department of Public Health. If you haven't met Lynn already, you definitely should, and Dr. Sosa has been just a fabulous partner for us over the last several months as we've been continuing to provide guidance around how to safely provide homeless services during COVID-19. And last but certainly not least, we have Dr. Emily Mosites, who is with the with the Centers for Disease Control and Prevention. Dr. Mosites has actually been one of the point people at CDC who's been specifically focused on assisting homeless services providers to adapt She's an epidemiologist there and is also a lieutenant commander in the U.S. Public Health Service Commission Corps. So we're really pleased that they can all join us with that. And with that, I'm going to turn this over to them. Please use the Q&A function at the bottom of your screen where you can type in questions, and we'll do our best to try to field those questions to our panelists. So please go ahead and do that. I think maybe one thing we can do to start is just to have someone from each agency just describe your roles. So perhaps we could start actually with you, Dr. Mosites, if you're with us. Just if you want to say a little bit about what CDC's been doing with respect to COVID and homelessness. Do we not have Dr. Mosites yet? Okay, why don't we start with you, Dr. Sosa, while we work on getting Emily on board.
Sure, thanks, Richard. Hi, everybody, and thanks for having me. I'm happy to be here. And first, I want to start off with a thank you for all of the hard work that all of you have been doing for this important population. So I'm, as Richard said, I'm the Deputy State Epidemiologist, and I'm one of the doctors at the State Health Department. And my job during COVID-19 has been varied, but one of the main jobs is overseeing our data collection related to COVID-19. So monitoring the trends in COVID-19 cases and understanding what is going on with our cases throughout the last 7 or 8, I don't know how many months into this that we are. And so kind of seeing that through in the spring when we saw our first big wave and into the little bit of the lull that we had over the summer. But if you follow our data reports, and we do put out a report every Monday through Friday with a more expanded weekly report on Thursdays. And so if you've been following, especially our Thursday reports, you'll see that we have definitely been seeing increases in cases throughout the state over the last 6 weeks or so, with a lot of that increase in southeastern Connecticut. And that's not really that surprising. In the first wave of the pandemic, we saw our southwestern part of the state was really where COVID-19 was first introduced, and clearly was related to what was going on in New York City. The southeastern part of the state was not as severely affected. So it makes sense that now, as we see these increases again, that it is southeastern Connecticut that is being more severely affected. But I want to be clear that we are seeing increases throughout the state. And so obviously that's really important, and that awareness is important as we think about how we protect all of our various populations, and the homeless population in particular. So thank you.
Thank you, Dr. Sosa. Dr. Mosites, thank you so much for joining us with your busy schedule. I see also you're in uniform, so if you could just say a quick word about who you are, your role at CDC, and also in the Public Health Service.
Sure, thank you so much, and I'm so sorry for being a couple minutes late. It seems to be inevitable that my computer decides to restart on a regular basis, so I think it's also gotten tired of this pandemic. So I'm Emily Mosites. I am with the Homelessness Unit in the CDC COVID-19 response. We started the unit in March, so we've been working specifically around response related to people experiencing homelessness since then. We do a couple big buckets of things. One is we write the CDC guidance related to homelessness and COVID-19 prevention. We also provide technical assistance to states and local health departments. We've done several deployments out into the field, and we also do lots of calls and just problem solving with people who are working on the ground. And then we're doing data collection to try to inform our guidance so that we can understand what's working, what's not working. So we have a couple different data collection projects. And then we also have a couple implementation projects in a couple different realms in coordination with the CDC Foundation. So I'm really glad to be with you guys here today. I'm happy to answer questions about CDC guidance or about the approaches that we've been using. And I'm so grateful for all the work that you guys have been doing on the ground. It's really helpful for us to hear from you and to hear the types of questions you have, because that can help us better, understand what's going on and better see how we can support you.
Thank you so much, Dr. Mosites. And again, I want to encourage everyone to try to use the Q&A function at the bottom of your screen. Get your questions in now, so we can get those answers. So Steve or Leigh or Kara, do you want to just say a quick word about DOH and your role in all of this?
Thanks, Richard. Thanks, everyone, for being here today. So, as you know, I'm Steve DiLella, the Connecticut Department of Housing, and we really have been on the front lines of COVID, and I really would like to reiterate what Dr. Sosa and Dr. Mosites said about our shelter workers who really have done an incredible job throughout this pandemic, especially in the early days when there was a lot of uncertainty and a lot of just fear of how this could spread amongst the homeless population, and even going to work every day knowing that they're putting themselves at risks. So certainly want to thank them for all their hard work and everything that you do for us. So DOH has been in a role that really has tried to support the needs for the folks that are on the front lines, and we've really been relying on you to tell us what are the needs, what are things that you need to have. In early days, it really was about trying to identify PPE and getting out that to all the relative providers, and now more recently, it's really been about how to safely house folks and shelter them in COVID. Really decompress those shelters, get our many housing resources as we can, and get people into permanent housing, because we all know that permanent housing is the best response to COVID, because if anybody has the opportunity to stay, self-isolate if they need to, quarantine if they need to, but overall just have a place to go so that they can live their lives in safety. So that has really been our focus since the summer, once we got the hotels stood up. So we're certainly looking to the future, want to continue our housing efforts, but obviously, as Dr. Sosa says, we're keeping an eye on the increasing rates, and we're here ready to support you with anything you need. So once again, you guys on the front lines are really the information bearers to us. We need to understand where you guys are so we can tailor our response in a more effective way.
Great, thanks, Steve. So again, want to invite you to type in your questions in the Q&A function below, and I want to just reiterate. No questions are too big or too small. This is like everything is safe here, and this is really about a chance to just answer any burning questions that you have about this. And so while we wait for you all to get your questions formulated and typed in, maybe I'll just warm everybody up a little bit and so throw a few questions out. So Dr. Mosites, if I could start with you, since you've been literally all over the country and responding to questions from all over the country, what are you seeing in terms of like trends where I know there's been a few outbreaks in shelters and homeless programs across the country? Is there anything you can say that is really driving those kind of outbreaks? Like what do you think is really driving? Is it about things that the shelters are doing? Is it about what's going on in the larger community? Can you say anything about that?
Sure, yeah. So it's true. We've been monitoring outbreaks as they've happened across the country. There have certainly been outbreaks within homeless shelters. One thing that's interesting is that, once COVID gets into a congregate setting, it can spread very quickly. So sometimes the size of an outbreak in a shelter can be unrelated to the community level of transmission that's going on, because it really just takes a couple introductions that can really make it take off within a shelter setting. So it's there's some elements of that is random chance. There's also an element of that has to do with using the protective measures that are laid out in the guidance. Most of what we've seen when we talk to shelters is that people have really leaned into protecting the people that they're serving. So most of the time, the spacing, wearing masks, those things are in place. And when we see better adherence to things like that, then we do see less spread, because inherently, if you have more space in between people, and if you have, in general, fewer people in a homeless shelter, then you're going to see less spread because you have fewer people for it to spread to, and it's harder to spread. So it's definitely come up across the country. We have, I would say it's a little hard to tell because we don't have a very good systematic way to compare cases among people experiencing homelessness to the general population. But I would say that we've, based on what we might have expected to see more outbreaks than we've seen. So I would say that, the shelters have really taken on the efforts to put these protection measures into place.
Great, thank you. I think you're right. We've been surprised at how low the rates have been in our own shelters in our state, and I think some of it is the proactive. It's one of those situations where it's hard to know what would have happened if we didn't do those preventive measures. So I'm glad we did take some of those preventive measures. Okay, so we have a couple of questions coming in. One of them is, and I'll just quote the question, that my biggest challenge, this is from Laura, I believe, my biggest challenge with my clients is to help them understand that wearing masks when we meet is a safety measure that protects me while my mask protects them. I also have many clients believe that COVID isn't real. Does anyone have any ideas about how to help them understand that this is real and the measures that we are taking will help? Anybody want to take that one?
I guess I'll start because we certainly hear that from other people, and maybe part of the reason that people might feel that way is because you all have done such a good job and they haven't been affected by the virus, but we certainly are aware of many people have been affected by the virus, and I think that part of that is just explaining that even though they haven't been affected, we know that a lot of people have, and certainly in Connecticut, unfortunately, we have had a lot of deaths, and I would argue disproportionately for our population. And so, and again, most of those being in nursing homes, which are certainly different than homeless shelters. But what happened in our nursing homes in the first wave is what we're trying to prevent, and what you all have done such a good job doing so far. So I think it's really emphasizing that even though they feel like they haven't really been affected, it is real, and to continue to enjoy these low rates in these settings, we need to make sure that we're doing all of these things. And sometimes it might be that, even if you feel like you're fine, if you do these things, you're protecting other people. And sometimes that's an argument that, or a discussion that works. They say, okay, well, yeah, you doing this is going to help everybody else.
And I think it really is important to kind of rely on your training in motivational interviewing and all the skills that you have generated as shelter directors and as case managers to really try to find what is that niche that will really help one person understand. I think you all know that a lot of times it's different ideas for different people, so it's really trying to understand where that person is coming from. And I agree with Dr. Sosa, just try to explain, how this has, taken its course throughout the state. While we may be in a good spot, or we were in a better spot in the summer, but while we may be in an okay spot now, we don't want to go back to where we were in the spring, where especially in congregate settings, COVID was spreading, and we're trying everything we can to keep that from happening. So, it could be an acknowledgement that, yeah, we've done a good job, and we don't really see it within our homeless world too much, but we have to be vigilant. We have to keep going to really keep it from spreading.
And I would just add too, Steve, that is to try to normalize this as much as possible. And so if your shelter guests are moving about in the community, just like all of us, we're all wearing masks if we're out in public. And so certainly your shelter setting is no different than if they were to go to the corner store or to the grocery store, or move about in the community like they often do.
Great, thanks. So another question's coming in, and this is something that I know has been on everybody's mind. Winter is coming. I hope that's not a trademark phrase from HBO, but winter is coming, and we all know that's when shelter demand increases. So the question is, do the panelists have any recommendations for ramping up either current practices or adopting new practices that they can implement with the winter months approaching?
So I think I know from DOH's perspective, we really have been thinking about how best to move forward with the winter, and we've really been collaborating with our CAN leadership folks who are in turn communicating with the frontline providers to really determine what their needs are. So I think once again, it really is about information sharing. We need to know currently as much information as we can. So we're trying our best to provide the funding that is needed to ensure that we have at least the same number of bed space that we had last winter. We know it's going to look a lot different. Most of our shelters are at reduced capacity. Most of our warming centers will not necessarily be the most appropriate place for COVID because they tend to be more open air, large rooms. So each of the CAN communities are really trying to identify what is the best measure to be able to have these beds. In some cases, it is in similar type facilities as last year, but with lower capacity. In other cases, it is hotels. So we're just trying to support whatever is requested of us. And obviously, we need to know if we're starting to see any uptake or any positive cases, I think, so we can best respond. I think you also know that we've been on a testing protocol, so we've certainly been able to go out and test the vast majority of shelters across the state. So we continue to intend to continue to do that testing. I know the governor recently provided the funding to be able to continue to test to the end of the calendar year, and obviously reevaluate when we get closer to that. So we're also working to identify if there are some hotspots, is there ways to increase testing so we can kind of at least know the most up-to-date information so we can be as effective in our response as possible.
I was also talking with I was just going to say I was talking with a shelter provider yesterday, and they have been working very closely with their FQHC in the community, and the FQHC has been coming out to do regular testing for COVID, but they have a request in now to the FQHC provider to actually come out to do a flu clinic directly at their shelter, which is not something that they typically provide during the winter months to their shelter guests. But certainly, you know, in light of ramping up as we approach flu season, this is going to be their intervention to try to mitigate against that.
I would pick up on something, Steve, you mentioned, and maybe this is for Dr. Mosites or Dr. Sosa, which is, you know, at the beginning of the pandemic, we thought big open spaces with lots of beds was dangerous. And then we thought keeping people in separate rooms was safer. Nowadays, I know providers are putting plexiglass dividers and other things to try to protect. Like, what's the latest on facility design? You know, warming centers tend to be in church basements or in large sort of big open rooms. Like, what's the right configuration here? It's been a little confusing.
So Lynn, I can let you respond and then I can jump in, or?
Why don't you start?
Okay. So, well, I want to say a couple of things. One is that when we're thinking about winter, COVID hasn't changed, unfortunately, so our guidance doesn't change when we come into the winter. So for the most part, we're going to be keeping the same principles of prevention going as we go into the winter. There's a couple things that we do recommend thinking about the winter, and I will get to your point, I promise, Richard. One is checking in on your HVAC system, checking in on your ventilation. Another is to, in those spaces that might be opened for warming centers or for overflow shelters, run through our guidance tool, and you can just check off, make sure you have protections in place when you're opening something new, and that's on our website on the resource page. And then finally, flu vaccine is another thing that we just want to make sure everybody's getting a hold of. So when we think about our ventilation is very important. Space is very important. A major underpinning piece of our guidance is about creating more space between people and having people in their own rooms if possible. So just like at the beginning of the pandemic, it's still the best case scenario to have people in their own rooms. We do recommend, in our guidance, we have a recommendation if people are symptomatic in a symptomatic area to have barriers potentially around that person who's symptomatic. But otherwise, the evidence is a bit scarce on barriers. On the one hand, they could help prevent, you know, kind of like a mask, they could help prevent droplets from spreading from a person who's COVID positive. But on the other hand, if you have a big open space, depending on the layout, this is why it's a little hard to answer. You know, it's kind of case by case. They could be impeding airflow, and you want to have good airflow to clear out potential viral particles. So it's a little bit mixed, and it's a little bit hard to say on a broad scale what that might look like. But I will say that we are putting through an update with a lot of details on HVAC in general that should hopefully be out in the next week or so. On our website, they can get at some of the other questions about how to improve that airflow.
Yeah, so I don't know that I have much to add there. I think it's important to just continue to emphasize all of the things that we have been doing throughout, because those are the things that we have the most experience with, and those are the things that we think work. I know that there's been a lot of press about the potential for aerosolization of this virus, but I just want to be clear that that's not something that's necessarily new. But I think the other thing here is that the primary spread of the virus is those droplets. So, and that's why the distance is so important. So as long as we can maintain distance and we can have that masking and washing hands and doing all of those things, that is really where we're most concerned and where we need to emphasize, because that's how most of the transmission for this virus happens. And then, you know, where the issues that Dr. Mosites brought up in terms of the HVAC and things like that, that can help address whether, you know, where there might be very specific situations where the virus could spread in other situations. But I think in these settings, doubling down on that spacing and the masking and the cleaning and the disinfection is key, and clearly has worked so far, especially in Connecticut. And so I think that's really important. I think the other point is that in the winter months, right? So part of the reason we're all worried about winter is not just because we're all inside, but because we're worried about the other diseases that we know spread in winter already, like the flu and like the other respiratory diseases. So there's no reason to think that all of these things that we're doing for COVID should also work for those other diseases. And so that's going to be helpful too, and hopefully keeping all of the disease down for winter. And obviously, I know there's already a question about flu vaccine. The more people we can get vaccinated against the flu, that's just another tool in our toolbox for this winter.
So is that something, Dr. Sosa, that shelter providers should be doing? Should they be trying to get as many people, residents, guests in their shelters and their staff vaccinated for the flu? Is that
yes, they should. Yes, and I was very happy to hear that one shelter is already working with their local FQHC. They're a great resource. They have flu shots. They are advertising. They want to get it out to folks, and so that's a great partner for getting that to your population who is vulnerable, just, you know, in terms of the setting, but also we know that many of them also have risk factors for more severe complications from the flu. So this is absolutely a population that we want to get vaccinated.
So a follow-up question came in from the Q&A about which agencies are willing to come out to actually give flu shots and that accept all insurances. Dr. Sosa, you mentioned federally qualified health centers, community health centers. Would you say that's one of the best places to go for flu shots?
Yeah, absolutely. I know that, you know, there's visiting nurses associations, and honestly, there might be pharmacies. I know that the pharmacies are making a big push on this, and I don't know all the details there, but I think there's just so much more awareness about flu this year and emphasis on flu vaccine. So I think I'm hoping that translates to resources in the community, and I think it should not be hard to find somebody willing to provide flu vaccine to anybody this year.
Great. So we have a question from Hoween Flexer about with the second wave, or I guess community transmission rates going up. Are we planning to continue to utilize hotel space? I don't know. Maybe Steve, that's a question for you.
Sure. So we currently have 4 hotels still operating in the month of October. We have one in Hartford, one in Danbury, one in New Haven, and one in Stamford. So the first 3 that I mentioned, we're continuing to plan on having them open throughout the winter season if needed, and we believe that they will be needed. If once again, we've been working with the cans to identify the proper space. So there are some cans that are requesting hotel space for their cold weather protocol. So we'll certainly be responsive to that and set those things up when the time is right. And once again, as we really try to see how the winter is going to go, if that needs to be an option, we certainly will be able to access those hotels. Once again, one big piece of this is FEMA needs to continue to reimburse us for that, but at this point I see no indication that they will not. They've been really great to us to this point, and we continue to expect them to be extremely responsive. So I believe that this could be an option through the winter season.
Great. So we had a question coming in about the way that we structure shelters. I know this has been something we've discussed and kind of been all over the place on as a network. We've, question is it, should we not have people congregated in closed space? Should we be looking at different structures? I know ideas have been thrown out about converting shelters more into SRO-like settings. I know nowadays I'm hearing like keeping people spread apart in a large space as long as you have good ventilation. So like, Tara, why don't you start? And then I'd love to hear also from Dr. Mosites on what other communities are doing across the country.
So I just wanted to jump in. We asked Lou Gilbert from Imacare to jump on today but he's really busy finishing up the renovation of the shelter. And some of the things they did in renovating Imacare, I think really are going to be helpful overall to kind of prevent the spread of COVID. So if you're familiar with the shelter, it was like 70 beds, 35 bunk beds in a church basement. They completely got renovated this church, and when they put the bunk beds back in, they built divider walls on on three sides, or the back side of the bunk bed, to kind of create privacy, but it also has set up kind of a natural partition like a plexiglass barrier or curtain would have done. So I think that was intended to give privacy and also have a place for people to put plugs to charge their phones. But really kind of is now coming in handy with the spread of COVID. So building barrier walls between the beds, I think if you have to be in a congregate space is helpful. Something Lou also did that's really kind of neat, in his second floor, he built these little standalone pods. It's a very big open room, but he built these little kind of almost like tiny homes in a building that are for, it was going to be like an intern program or kind of SRO type rental for people who are really kind of disabled and not able to live anywhere else. So those are completely self-contained little rooms with their own ventilation system. So these are two things that if you are doing construction to your building, you can do within a open congregate setting just to make things a little bit safer.
Thank you, Kara. I know Lou at Imacare, they added one of those UV, I don't know what they're called exactly, but ultraviolet device on their HVAC system as well. So that's just another way that some of the kind of microbes and things could be destroyed. Again, I'm not a scientist, so I'm a little out of my element. Dr. Mosites, anything you want to add? Dr. Sosa, please jump in as well.
I'm sure, just in terms of what other communities have been doing, what we have heard a lot of is actually purchase of hotels. Hotels that are being used right now across the country. People are using hotels for non-congregate sheltering, for isolation, quarantine, or for protective housing for people who are at highest risk. And so most of what we've heard in this space is really just discussion of, well, let's purchase that hotel and use that as a shelter or as a form of permanent supportive housing, lots of discussions around that. So that's most of what I've heard, but I can hand it over to Lynn to see if she has anything else to add.
No, I don't have anything to add. I think clearly the strategy that was undertaken very early on in the pandemic here in Connecticut and moving and really depopulating the shelters in a variety of ways, whether that was being able to secure permanent housing for I believe almost half of the homeless population, and then being able to house a majority of the rest in a hotel situation really made a big impact.
So again, want to encourage everyone, keep your questions typed in. I have a ton of my own questions, so I can keep going all day, but I know I want to hear from you all about your questions. One of the things that we're struggling with as a state, and I agree, we've done a really great job as a state, and again, I want to echo the thanks to all of you for your amazing work. At the same time, we know lots of people are not getting accepted to shelter these days. We're actually, there's some increasing shelter diversion, but a lot of people are being added to shelter wait lists, and shelter admissions are still down. And with winter coming, one of the questions is, how do we weigh the relative risks of not providing people shelter in the colder weather months, but then also not filling up our shelters back up? And so it feels like there's not a clear answer on what's safe. So how should we be thinking about the relative safety here? Like what's the best way to think about meeting shelter needs while also not congregating shelters to the point where it becomes a COVID risk again?
So I think from our perspective, once again, we've really been having these conversations with the CANs, and ultimately our goal is to keep the number of beds available in each community at the same level it was last year. However, we also know that because of COVID, most of our facilities are not going to be at the same capacity. So what that really means is we're going to have a lot more facilities around the local community, around the CAN, that are going to be open and available to be able to manage that capacity. And I think some of those plans are still in effect. We've been lucky enough to receive funding from the federal government, both from FEMA, like I mentioned before, but as well as through our ESG grants, and as well as CDBG. And we certainly are looking toward those funding streams to be able to provide the necessary resources that will at least provide that similar level of bed coverage that we had last year, even though we know that it's going to be spread out across communities.
I want to say it sounds like Steve is exactly on the right track there. I think what you want to avoid is getting to a place where you're making that decision at the door, where you're saying, we're full, it's freezing cold outside, and we don't have a space for this person. So I think, having those conversations now and making sure that space is available is what the northern states are looking into right now.
Great, thanks. I want to turn to the question about testing. We, as Steve mentioned, our state has begun testing shelter facilities, and we've done that. And so far, we've found low rates. Although one thing that I know Linda Casey on our team, who has been making sure we capture that data in HMIS, is noting that we're still only testing a fraction of the people who are enrolled in shelters. And so one of the questions is, should we be getting to universal testing? And if so, what frequency? Is that at some point, I know somebody asked, shouldn't we be testing everybody every week or every other week, and making sure that every single person is tested? So how should we be thinking about testing?
So I'll start. I guess it is definitely a fine balance. I think certainly we want to make sure that testing is available to this population in all of our communities. And so if that's not happening on a regular basis for whatever reason, those opportunities exist. Basically, all of the federally qualified health centers are on contract with the state and can offer testing for free at this point. And certainly this would be a population that would be an important population to make sure that it is served. And so our testing guidance for these types of populations has really focused on offering monthly testing, especially in our communities that we know are have already been disproportionately affected, where certainly a lot of our homeless shelters or homeless providers might be. But I certainly recognize the diversity of Connecticut, and there are homeless shelters that might not be in those exact communities. And so certainly those maybe would be the opportunities to, reach out to the federally qualified health center and make sure that facility is able to take part in, I would say, at least monthly testing. And I think part of this is just making it routine, and so that people are aware. It's like, hey, this is the testing opportunities in our community, and making sure that people know that it's available at the shelter, in addition to all the other places in the community where testing is available. And there's certainly been so much work in making sure that the availability of testing is a lot more widespread. Now that we're seeing communities, especially in southeastern Connecticut, that are seeing pretty dramatic increases, and folks are aware that alerts have been raised for both Norwich and New London, I think those are communities where we really should be increasing the testing of those populations. And the frequency, I don't know that there's an exact frequency. I don't know if Dr. Mosites has input on that. I think at least weekly probably makes sense for those shelters. And again, it's working with the testing partners that are in those communities. And I know both of those communities have federally qualified health centers that I think would be the best places to reach to make sure that the testing is available specifically for those communities, in addition to all the other testing that is being increased to address the increased rates in those towns specifically. But again, across southeastern Connecticut right now, which is kind of where the focus of the increases has been.
Yeah, thanks, Dr. Sosa. That's exactly aligned with the way that we think about it as well, is universal testing. We kind of think about testing in two different ways. Universal testing, when community spread is pretty high, we recommend getting in there at least once and doing universal testing, and then repeating that universal testing every week or so until there's no more cases identified. The reason for that is because universal testing is not just a means of finding out if there are cases going on, but it's also a means of interrupting transmission. So you can test everyone and then isolate the people that are positive, and that can help cut down the outbreak. Another way of thinking about testing is actually to detect if transmission is going on, and then using universal testing to interrupt it. So that in our guidance, we call that like active surveillance. So in that kind of situation, you can test a subset of people on a regular basis, say weekly. And if you identify any cases, then you do universal testing to start trying to interrupt transmission. So those are two ways to think about it. Seattle's using that active surveillance type testing, where they have academic partners who are going in on a really regular basis, I think a couple times a week, and testing. I'm pretty sure it's voluntary. They have people just come up, do testing, and then anytime they get a positive case, they go in and they call it surge testing, where they do universal testing. So there are a couple different options, ways to do it, and it very much depends on what's happening in the community and should be flexible to the availability of tests, of course, and then also what community transmission looks like.
Right, and I would emphasize that, especially in Norwich and New London, that testing should be done in conjunction with the local health department, because the key is, the reason you're doing the testing is you're worried that you're missing cases, that there are cases that you don't know about. So the response to those cases and being able to isolate and quarantine as quickly as possible, so isolate the cases, quarantine any contacts, is going to be so important. So making sure that there's a plan in place before the testing is done is probably a good idea, so that everyone knows what's going to happen, because you're going to expect to find people that are infected.
I think that's super helpful, just to think about testing not as something that just needs to happen on a routine basis, but to think about it strategically. So you use testing as a way to kind of surveil and monitor the situation, but also, as you noted, Dr. Mosites, to interrupt community transmission. So if you find cases, that's when you want to test everybody, but you can do it in a sampled approach. I think we probably as a state need to work on refining our testing strategy overall, because I think to date it's been pretty broad, and we've been lucky in that we've had low transmission. But Dr. Sosa, as you've noted, now that we're seeing a spike in cases in the southeast part of our state, maybe that's where we need to have a more kind of surgical, strategic approach to this. I want to mention somebody, Kathy, in the Q&A mentioned the community resource coordinators as a new resource that our state has created. These are folks who can assist with facilitating isolation in the case where people are positive. They also have access to some special flexible resources in the case they need to help facilitate isolation. So it's another resource that has been made more broadly available, particularly for low-income and vulnerable populations, but that includes people experiencing homelessness. We have a question coming in from Paris about whether shelters might think about creating one-way enter and exit, so ensuring that people aren't passing each other in the hallway, but really figuring out how to keep flow. Is that something that shelters should be thinking about?
I will go out on a limb and say yes. I think whatever the opportunity is to create that distance between people, including being able to, streamline movement in a facility, is going to make a lot of sense.
Thanks, and I think DOH certainly is supportive of that as well. We also know that it may not be possible in some cases just by the way the physical structure of the building is laid out, but if you guys have ideas on modifications that you may need, please let us know. We can try to be able to work that out. Maybe give some capital funding if it's possible, but obviously that's going to require a lot more innovation and investment to determine how best to do that. So if you can do it as you are now, great, let's do it. If you need additional resources, just let me know.
Great. I want to circle back real quick. I remember another question came in to me through another channel about testing. One of the things that's come up in our community conversations is the value of antibody testing as opposed to the kind of regular testing that we've been doing for COVID-19. Can you, either Dr. Sosa or Dr. Mosites, speak to the value of antibody testing? Is that something that we should be thinking about or doing within the homeless shelter and services community?
So the short answer is no. The testing that we're focused on is still using those PCR tests that people have been hearing about, and basically those tests are detecting actual pieces of the genetic material of the virus and really are used to diagnose infection, and that's really what our focus is. Antibody testing will hopefully be helpful in the future, but I think we're still in a place where we need to learn more about it. We need to learn more about how immunity to the virus happens, how long it is good for, and that makes it really challenging right now for us to understand and how to interpret an antibody test, which is looking at our body's response to see whether the body has seen the virus before and actually what that means. And I think we're just not in a place to be able to use these tests on a widespread basis in terms of being able to say, okay, if somebody's antibody test is positive, that means that they're safe from the virus or less likely to be infected or don't have to isolate and quarantine. We're just not really in a place to be able to use those tests at that level yet.
I agree.
Great. If I was a TV talk show host, I'd be trying to invite controversy between all of you, but you all are in such great alignment. So so far, that's been great. Another question came in about what are the financial and technical kind of architecture, public health design consulting resources that might be available for facilities that want to undertake kind of redesign or renovation of their shelter facilities, similar to what Immacare did. I don't know, maybe that's a question for DOH. Is there any resources you can think of that can help shelter providers to think about, getting some design consulting or some resources to hire a design or architectural consultant, and any thoughts on like who's been doing that well?
Certainly, it's a little bit different for the shelter world, but obviously from the regular DOH world in terms of building affordable housing, there certainly is pre-development loans out there that are available to kind of help folks think through this. But that's, for the most part, just the general operating business that we've had for years and years. I think this is such a new territory. I am not aware of any public health design consultants that can really help us kind of think through that. I think Lou was just in a situation where he was redesigning his shelter as is anyways, and just kind of COVID happened right in the middle of it. But even beyond that, there certainly was some thoughts previously on some of those pod efforts that not necessarily were for public health issues, but were for other issues related to how to effectively operate shelter and have different levels within a shelter that made sense, but can easily be used in certain circumstances to address public health issues. So I think it's something we could look a little bit more deeply into. I'm sure there probably is some new startups or some new divisions within architectural firms or design platforms that really is starting to look at how better to design a facility for COVID. But we'd certainly be interested in looking at it, but I don't have any resources today.
Dr. Mosites, you mentioned some guidance that CDC is going to release soon about facilities and ventilation and HVAC. I know you pointed us to, and I know that the CDC's FAQs for homeless service providers points to the office building guidance, but can you talk about like when we might expect to see the guidance that might be more specific to homeless shelter and service settings?
Sure, it's really just a translation of that office guidance to be more appropriate for homeless shelters. And the things that you want to think about are increasing airflow, making sure that you're getting as much outside air as possible, and just kind of doing that in the context of, potentially cold weather. So reaching out to an HVAC professional and talking through some of those things. I mean, you can kind of like bring the office guidance or our guidance with you and say, hey, I just want to check on these couple things. Hopefully it's going to be posted in the next. I always hesitate to say. It's hard to know exactly. And anytime I make a prediction, it's always like a week after that. So I'll say next week, and then we can expect that it'll be the week after that.
Having worked in the federal government, Dr. Mosites, I remember that it's always hard to predict how things go through the process, but appreciate that. We'll keep our eyes out for that guidance and share that with the panel. I want to turn to Kara and Leigh, I know you've been in many conversations locally and you've been hearing a lot of the conversations and questions that are coming up. What do you think are some of the burning questions or issues that you'd like to raise, or anything that you'd like to share with the homeless shelter and services community about what we should be doing or what should we think about?
Sorry, I'm also a second grade teacher this morning, and my pupil is right next to me, who's not listening. I think the biggest thing that we've been hearing is some confusion about requiring testing results as admission to shelter prior to admission, that we've had a lot of shelters requiring people to get a test result in order to come in. And I know we've issued in our guidance that we don't recommend that. We still want our shelters to be low barrier so people can come in. And I know it can be confusing because in the same breath, we're talking about universal testing and kind of having as much testing as possible in shelter, but we don't want to have a barrier for people to get into shelter. And we know testing can be sporadic as far as how quickly you can get the result. So some places have very rapid, 20-minute tests, which are harder to get, I think. And some people are getting results in 7 to 10 days. So we don't want people to wait for shelter. So I think what we've tried to work with shelters on is just focus on symptoms. People are most likely to transmit the virus if they're symptomatic. They're coughing, they have a fever. So do symptom screenings regularly. And that if everyone's using the PPE, wearing masks, staying distanced from each other, you're gonna really reduce the transmission by those safety measures. And that test actually can be a false sense of security. That's just a moment in time. So they may get that test on Tuesday and say they're negative, but they go to their sister's house on Wednesday and get exposed. You're still under the impression they're negative, but we really have just talked about the symptoms as where to spend your time and energy and focus.
Yeah, and I'll just echo that. I think that's really important. So, I mean, and the reason is exactly what you said, especially when we're doing tests on people who are asymptomatic, and depending what tests we're doing, the test might not be accurate, especially some of those more rapid tests. And so it can be a false sense of security. And the key is making sure that all the other things that we've been talking about, both in these settings and in our personal lives and in our homes, that we're continuing to do all those things. So even if someone has a negative test, does not mean that the next day that they could be positive if they were tested again. So I think it is really important to focus on people that are symptomatic and making sure that they are evaluated and get a test. And again, I would emphasize that that the the state contracted partners like federally qualified health centers are also working with contracted labs who are supposed to be offering and providing test results in a much more timely fashion. And so those would be, again, in these communities, the place to direct people, especially when they're sick, to say, okay, you need to get tested. Here's where you need to go. Certainly if people are really sick, they need to go to the hospital, right, and be evaluated there. So, but making sure that people are aware of what those resources are in the community. So I will say I was tested for the first time a couple of days ago, and it took less than 48 hours for me to get my test results. And that was from a federally qualified health center. So I think that it's gotten a lot better. And it's a matter of just making sure that people are aware of the specific resources and the best places to send their clients in their communities. And again, focusing on folks that are symptomatic. And even if someone comes and says, I have a negative test, that does not mean that you let your guard down, that anybody lets their guard down, and making sure that we're continuing to do all the things that we're doing, because that's what's going to prevent and limit transmission in these settings.
And we've asked shelters to really think about, in the event that someone is symptomatic, looking at your shelter layout to figure out where you might be able to quarantine someone while you are awaiting test results. We've had one shelter in the state that I'm aware of, the Eddy shelter in Middletown, that's actually been able to isolate individuals who have tested positive, and they have successfully been able to work with people who have tested positive while they remained in shelter. And I think they've done truly a phenomenal job, their staff, because they've really have not had increased rates of transmission, and their staff have not tested positive either throughout the duration of being able to shelter people while simultaneously isolating them. So they've done a fantastic job as well. I think the other thing that I'd like to add too is that, much of what we hear from shelters and staff who are in direct service with people is really the fear that they've been experiencing throughout this period, and wanting to acknowledge the reality of staff who are working in direct service to clients, particularly during this time, and certainly back in March and April and May, where things were a heightened sense of safety, I think, for all of us. And some of the creative things that communities have done are, again, like working with your FQHC to do some in-house training with your staff, and to be able to answer questions directly from the staff that are working hands-on with the clients day in and day out, and trying to do everything that we can to support our direct service staff, because I think reality is it has been a scary time for people.
Great. That's terrific. So we have just a couple minutes left. I want to see if maybe we could do a lightning round, if there's any kind of final thoughts, anything you want to share with the homeless shelter and services community about what they should be doing and thinking about. Maybe we'll start with you, Dr. Mosites.
Sure. I think our message is that you've been doing an absolutely outstanding job so far, and unfortunately we need to keep it up. You're doing really, really great. I know it's hard and it's a huge strain, and everybody's very tired. But these measures are working, and if we can hold on, I think we're gonna keep being in a pretty good place. So thank you so much for everything that you're doing. We're also available. I'm available. Our unit is available in the response at CDC for any questions or anything you want to just talk through.
Great. Dr. Sosa.
Yes, and just to add on to that, I think, yeah, we all have to, keeping on, and I would encourage shelter providers to continue to work with your local health departments, especially if you're seeing increases in your community, so that you can identify the best resources for the population that you're serving.
How about we go Leigh, Kara, and then Steve?
Sure. I would just echo what Dr. Sosa and Dr. Mosites has said, is to please keep reaching out to us with questions. And as you identify needs, please let us know what they are, because we want to continue to support you in all of your really great work that you're doing.
Yeah, same. Just don't try and go at it alone. You know, we're here to advocate for you. If you need more PPE, if you need help with a particularly challenging situation, that's what Leigh and I exist for. So just reach out and hopefully we can brainstorm a solution together.
I got to make it the fifth in a row. Totally agree with everybody. Maintain your vigilance. Keep doing the great work that you're doing. If something is going in the opposite direction, please let us know as soon as possible. We have the staff available to come up with creative ideas, and we do potentially have the funding available to make the necessary changes to be able to provide the safety for everybody that you serve, as well as for your own safety. So just keep in constant contact with us. Keep working through your cans as well. Let them know of any difficulties that you may have, and obviously kind of like circling back, we know this is about shelter, but ultimately the best answer for all the people we serve is permanent housing. So keep doing the great work that you're doing there with taking the folks that you serve and finding them places to live out in the community, because every person we have housed means that there's one more person that has that ability to be in their own apartment to ride out this pandemic. So I just want to give you kudos for that as well.
Great, thank you. So I know we're out of time, but one thing I really appreciate is just how our government partners have been made themselves so available to us at all levels. I know you all have so much going on, partners at Department of Housing. Dr. Sosa, I know you are incredibly busy, but thank you so much for your generous amount of time. And Dr. Mosites, thank you for being available to us, but also for all your work across the country and helping respond to COVID-19 at the federal level as well. And again, I want to echo my thanks to the homeless services provider, all of our members in our coalition and our network for all that you're doing every day. You're putting yourselves on the front lines at risk and doing your best to protect your staff and your populations and your clients. So thank you so much. With that, I'm going to close out. We could pull up the slide really quick, and I'm going to transition right. Coming up next, we have a great session on the changing nature of homeless outreach for unsheltered populations during COVID-19. And then at 12 noon, don't miss our Get Out the Vote rally, where we'll have some really fun but exciting and hopefully inspiring comments from Jerry Jones from the National Alliance to End Homelessness and other local efforts here to try to get out the vote among people experiencing homelessness. We have a virtual town hall with Hamden, the town of Hamden, on homelessness. At 3 o'clock, we have a great session on improving and reducing police responses to people in behavioral health crisis, featuring Department of Mental Health and Addiction Services and also Connecticut Mental Health Center and a couple of police departments as well. And then please join us for our 4 p.m. happy hour to close out our conference. So thank you all so much.